everyone. I am Hirokazu Kanegane from Department of Child Health and Development in TMDU. I have studied primary immunodeficiency diseases, alternatively, inborn errors of immunity for more than 20 years. XIAP deficiency was first identified as X-linked lymphoproliferative syndrome type 2 XLP2 in 2006. And this disease is mainly characterized by Epstein-Barr virus-driven hemophagocytic lymphohistiocytosis (HLH). International survey disclosed that the outcome of XIAP deficiency was poor, as the same as XLP1 subdeficiency. Interestingly, approximately 30% of patients with XIAP deficiency are associated with Crohn's disease like inflammatory bowel disease (IBD), which is refractory to conventional treatment. Only curative treatment for XIAP deficiency is allogeneic hematopoietic cell transplantation (HCT). International survey revealed the outcome after HCT was not satisfied. However, the better outcome after HCT was observed in a small cohort of Japan. In this study, we evaluated whether IBD associated with XIAP deficiency could be cured by HCT. We collected the data from 26 patients with XIAP deficiency throughout Japan. 22 patients, approximately 85%, survived. This outcome was excellent compared with the previous international data. However, many patients were associated with acute graft versus host disease GVHD and post-HCT HLH. In addition, patients from HLA mismatched donor and who had HLA activation at HCT showed a significantly poorer outcome. Interestingly, 2 patients successfully underwent HCT from HLA mismatched donor using post-transplantation cyclophosphamide. 19 patients were associated with refractory IBD before HCT. However, almost all the patients improved IBD after HCT. After HCT, colonoscopic and pathological findings changed to be normal. In addition, we investigated intestinal microbiome before and after HCT in 9 patients and their families. Microbiome study revealed that patients showed a different pattern of bacterial microbiota before HCT. This data suggested that dysbiosis play an important role in the pathogenesis of IBD in patients with XIAP deficiency. Interestingly, bacterial microbiota changed to be nearly normal after HCT. In conclusion, allogeneic HCT can rescue gut inflammation as well as dysbiosis in patients with XIAP deficiency. In the future plan, we would like to explore 2 points. The outcome of HCT for XIAP deficiency were almost favorable. However, the patients were at risk acute GVHD and post-HCT HLH. To reduce these complications, we changed the conditioning regimen based on the recently published paper. We modified the conditioning regimen including reduced alemutuzumab, fludarabine, and target busulfan. Target concentration of busulfan should be kept in 60 to 65 mg per liter time-hour. XIAP knockout mouse showed the abnormal intestinal organoid. We would like to explore the human intestinal organoid in XIAP deficiency. This study is going in collaboration with Dr. Okamoto's laboratory in Department of Gastroenterology and Hepatology in TMDU. Thank you for your kind attention.